Well, Happy New Year, everyone, and welcome to the 5th year celebration event. Really grateful to have all of you here. Again, my name is Brahmajee Nallamothu. I'm a cardiologist and health services researcher here at Michigan Medicine. I'm also one of the co-directors, as Sebastian has met, along with Sebastian and then Dr. Jenna Weens, who's also in the audience right there. And then Rachel Dawson, I also want to kind of acknowledge, our managing director, kind of helps make the operation move forward. It's really exciting to kind of be here and to talk with you guys. I have actually the best and the hardest job this morning. It's the best because I get to just come up here and talk a lot about you and your research and all the wonderful work you guys have been doing over the last 5 years. It's the hardest job because I had to kind of select things, and it's not easy to select from really a number of the dozens of examples that have just been amazing to kind of see. But we'll see how I did. I'm going to start with a broader question about what is precision health. This is really a non-trivial question. It's something that we've thought a lot about. In fact, it's something that I think many of the leaders of this group and initiative, and I saw Sachin here earlier, I'm not sure where he is, but like Sachin, Eric Mickelson, Gonzalo Abacasis, and many others kind of really pondered over as the launch of precision health started. It's interesting, the NIH specifically defines it as an emerging approach for disease prevention and treatment that takes into account people's individual variations in genetics, lifestyle, and environment. While that's a great definition kind of overall, there's a lot of ambiguities in it, and we have seen and benchmarked ourselves against other institutions, and we've learned a lot in terms of our framework and how we've thought about it. When you do think about it, you have this idea or conceptual view of like lots of different features that are associated with any individual's care. And then how do you combine these data types to really inform what happens at the bedside? And when this all started and stuff, we had this really interesting view. It built on things that had already existed here. Rachel mentioned that in the video, the Michigan Genomics Initiative, which was launched by Chad Brummett and others back about 10 years ago, and then has advanced through kind of the early recognition, and then eventually in January 20th of 2018, the official launch, so literally 5 years ago. What has been kind of an ongoing challenge has been, how do you take that vision of what we all think would be an idealized care situation, but how do we actually enable it so it can happen? And I wanted to echo some of the comments that Dean Runge just made, as well as some that Sebastian had thought about. And the early kind of founders of this really focused on 3 key areas. One was around resources and infrastructure. How do you build a compute environment and data infrastructure? This has been, I think one of our key advancements, and it's been done largely in partnership. I see Aaron Kaliba here with the Office of Research, and it's been just a wonderful way in which we've been able to move things forward quickly. The second comment, which others have made, and I think you're just going to keep hearing this time and time again, is this idea of multidisciplinary community, which we have invested deeply in. And I think the fact that all of you are here is a testament to what that means, and we've been really excited to see that develop. And then finally, I think early on there was this idea of really thinking about implementation and impact, and this is where I think we do distinguish ourselves from our peer institutions. I think from day one we've been thinking, how do we get these discoveries to actual public health, to actually change clinical care? And by combining all of these ideas and stuff, we have felt that our approach is more holistic, that each of these actually feeds on the other. And when it works, and we've seen great examples of this, and you'll see some of these later, we think it just really elevates everybody's work and just excites us as we move forward. So I'm going to go through kind of as an overview what I call our numbers, some of the quantitative reporting statistics that many programs like Precision Health across campus oftentimes give as kind of annual reports and updates. I'm going to talk a little bit about our stories, because it's not just always about the numbers, and just highlight a few key examples. And then finally, I want to talk to you guys a little bit about our future, But I'm going to leave a lot of that to Jenna in the afternoon when she kind of goes through some of our visioning exercise. But I want to tell you where we're at in terms of thinking about the 3 key priority areas that have been jumping out at us. All right, so our numbers. So again, you'll find these like in any annual report of an institute or center on campus, but we have 282 members. 60 just joined in 2022, suggesting that we're continuing to grow, which we're really excited about. We're very faculty focused. About 251 of those members are faculty. And it's not surprising. I think if you randomly pick 250 members from the University of Michigan, they would have 2,000 publications. But we're particularly proud of these. And I think some of them have been really high impact and have really changed the field. As Dean Runge had mentioned, there are 15 schools, colleges, and institutes. And when you think about the grants that have been received by our members, many of them are outside of Michigan Medicine and the medical school, but in terms of health-related funding, it exceeds $50 million. And there are a number of partner groups across campus that have been a part of that. One of the things that has been really special, I think, is the compute and analytics infrastructure that's been built. And again, I mentioned the partnership we've had with the Office of Research, but it's really allowed for a broader use of these data resources. In retrospect, it seems kind of obvious, but I just want to emphasize that what Dean Runge had said was true, that there was this view, whether it was real or not, that Michigan Medicine did not have the ability to easily share data. But I think that that has been something that has changed considerably. There's hundreds of data downloads, lots of users from across campus. We have nearly 800 research consultations that have been done through scientific facilitators, thousands of queries on the self-service tools, and then multiple data sets that have been integrated within the Michigan EHR data as well. And these have all been really important advances. And it really builds on this idea of a precision health analytics platform that has tried to, again, bring all these different data elements, create both a self-service tool, resources, and support. And much of this, again, I just want to say, has been such a great partnership with the IT groups at Michigan Medicine, as well as at main campus, and largely led by, again, Aaron Kaliba, Sachin Ketter-Paul, Jeremy Jarrett. There's so many people here that have played a big role in kind of actually actualizing this vision. All right. A couple of other areas that I think are really important to highlight. One is with education. Very early on, there was an education and training work stream that was developed. For a long time, I have to admit that the seminars tended to be very research focused. And one of the things that we did was kind of listen to feedback from many of the members in our community. And about a year or so ago, we were able to work with Cornelius James, who is a general internist here at Michigan Medicine, and actually revamp our seminar series to broaden it to beyond research, but then also to help clinicians and bedside providers start to understand what are the implications of some of these new advancements in precision health. And through this, we've been able to really create, I think, a vibrant seminar series. These are just 3 examples of some topics that generated a lot of interest last year. One of which was, Karandeep Singh had a wonderful one that, had over 150 attendees, and then hundreds of downloads, actually, even independent of that, that was focused on some of the questions around AI and ML tools as they're starting to make their way into EHRs. And I think those kinds of broad topics that are of general interest to both research communities and clinician communities has been kind of our change in focus and really been an exciting way in which we've been moving forward. The grants program, when Precision Health was initially envisioned, there was about $8 million that was set aside for a grants program. The way that we have thought about distributing this has been through both investigator awards that typically go to mid-career faculty, as well as scholars awards. One of the unique things about the grants program and an explicit criteria was that it had to require multidisciplinary collaboration and work. And this has led to, I think, some really exciting science. and some deep relationships. As Dr. Runge alluded to, sometimes like collaborations are, I'll give you some of my lab, you give me some of your lab, and we'll work together for a few months. But these have actually generated partnership. And one of the things that keeps coming up is like this question of return on investment with investments like Precision Health. And I can tell you, when we look back at the first 2 years of the grants program in 2018 and 2019, you can see that both have led directly on towards extramural funding, yielding like 2 to 3 times returns from the original investments. And in 2020, we had to pause the program because of the COVID-19 pandemic, but we were able to restart it again, and we're excited to see what the ultimate kind of yield is from that last group of funding as well. And then finally, I want to talk a little bit about the Precision Health Graduate Certificate Student Program. This is a program that's available campus-wide. It's actually pretty unique. We were the first university in the United States to have such a certificate program. And this is just a list of students from the last couple of years. And it just to tell you, it includes, like in this situation, almost 20 students from about 6 schools across campus. So again, just showing you the breadth of involvement. And this has been something that we've gotten excellent feedback from the student groups as well. All right, so I'm going to turn my attention now a little bit to a couple of stories here, because I think that those are always so much, they're so interesting and they're so important in terms of actually enriching some of those numbers. And I'm going to start with research impact, and these are just 3 stories. Some of these have been kind of alluded to a little bit in the video and in earlier discussion, but they kind of give you a sense of what I think are important areas. When you think about local impact, because I think it's very important for us to think about how we change our own health system and our own health care that we provide on a day-to-day basis at Michigan Medicine. One example that I oftentimes like to use is the example, like Jenna Weens's team has looked at this for a number of years about creating better prediction models for C. difficile infections. Those are hospital-acquired infections. They cost a lot of money. They cause a lot of morbidity. And they are preventable. And one of the things that Jenna has been working on for years is trying to understand how we can use EHR data to better predict that and then maybe intervene and change things. And I'll talk about this a little bit later, but her work now is implemented in the University of Michigan Health System, and that is not a small feat. I mean, the world is not lacking for prediction models. What it's lacking for is prediction models that people actually use and change clinical care. And this is a really big step. And I have to say that Precision Health played a huge role in this. The implementation team, Hammy is here. She was a part of that work stream that helped us push this through and get this vision in place. You heard a little bit in the video about the racial bias and pulse oximetry findings. This was led by Mike Schoding. And it leveraged the existing resources that we had through Precision Health to quickly answer this question. Mike Schoding is a critical care doctor here, and very early on in the pandemic, they were noticing that there were differences in pulse oximetry, which is a non-invasive measure, and invasive measurements of blood oxygenation levels, and in African American patients versus white patients. And so they quickly looked at this and were able to establish that this is not just a one-off finding, but this is a systematic bias that exists. And I think what's exciting about this is it's had really broad national impact. The highlight was about a year or so ago, Senators Warren, Booker, they actually wrote a letter to the FDA highlighting this finding directly from this study and prompting the FDA to relook at its examination of how devices are designed and evaluated across diverse ethnic groups. And then the final thing I just want to give an example for is, we have used these data to really partner more broadly and think internationally. And, the MGI data have now been combined with samples from biobanks around the world. And this has led to a number of new genetic findings, and then also really connected our researchers to these other biobanks in a really important way. So there are 2 special stories that I want to tell. One is around the precision opioid prescribing use case. So when Precision Health was funded, there was a use case that was launched almost immediately, and this was around this topic. You know, obviously at that time there was predating the COVID pandemic was the opioid epidemic that was hitting much of the United States, led by Drs. Amy Bonner and Chad Brumett. The precision opioid prescribing use case was trying to focus on how we could potentially use data here at the University of Michigan and then more broadly to really address this challenge. And I just wanted to highlight a few kind of bullet points here. I asked Chad for some summaries, and Chad is the most enthusiastic and inspirational person I know in this space, and there's about a dozen more that I left off. So I just picked these 4, but these are really, I think, just impressive. One is that they have started to use MGI data, for example, to understand novel genetic associations for new persistent opioid use, which is a big problem after surgery. They've been able to link clinical cohort data to drug monitoring program data at the state level. And that has been for research purposes and really changed, I think, how we can kind of view interventions in this space. The third point is they have developed and disseminated evidence-based acute care opioid prescribing guide to lower opioid misuse in Michigan. And through some elegant kind of econometric analyses, they've shown that the decrease in the number of pills per surgery is about 11. And as many of the folks who live in this space know, one of the biggest contributors to the opioid epidemic is prescribed opioids from healthcare settings. And then finally, this is just super impressive, but they've gotten $38 million in funding by diverse teams from multiple external sponsors. I mean, that $38 million in funding includes 9 schools across campus, and probably the most interesting collaboration I've seen is the collaboration that Chad has had with the School of Music, Theater, and Dance. And I don't know for sure, but I think it's probably the only combined grant between Michigan Medicine and the School of Music, Theater, and Dance. And to get extramural funding to really work on a dissemination project that I think is quite unique. It was to create a musical called Painless that was actually performed for the first time just this past fall. It was scheduled multiple times, but the COVID-19 pandemic actually delayed its launch. And then last fall, it showed for the first time at Community High School here in Ann Arbor, which was exciting. NBC Today Show actually came and did a special on it. And that is not the homecoming king of Ann Arbor Community High, but that's actually Chad, who looks very high schoolish amongst these young folks. So that was really exciting to see. And he's just been really just, just an inspiration in terms of getting this over the finish line. The other use case that started a little bit later, but has been really exciting and so relevant to many of the problems and concerns we have right now, is tackling mental health care access challenges. Again, Amy Bonner and this time in partnership with Surgeon Sen have launched the PROMPT study, which is, I think it's providing mental health treatment for precision treatment or something like that. Great acronym though, and they have done a number of successful things too. They've enrolled over 2,000 participants. And what's unique about this study is it's a mobile health study, so it's actually collecting data through an activity tracker as well as through smartphones, and also delivering interventions through a mobile app as well. They've shown strong engagement with greater than 90% of surveys completed, over 80% have daily mood scores, and then even delivering about almost up to an hour of mental health, mobile health interventions each week to the participants. This has really been trying to target the idea that there's a delay between actual referral for mental health care and being able to seek treatment. One of the really unique things is the shareable campus-wide data resource that's been created from this that includes kind of de-identified data, but the linked survey, mobile health data, and EHR data all combined together. And I was just telling Surgeon and Amy, like, when we look at it right now, there are 22 unique users who've actually accessed this data already and started to analyze it, which is really special to see, and again, from across campus. And for those of you who live in this space, it might not be as surprising, but for others, I mean, this is really a different way and model of how to collect and then distribute data. And then finally, they were able to get an R01 funding to see that this work will continue, and then also have future funding in plan. So I'm going to end with just a quick discussion about our future and how we see it. Again, Jenna will get into this a little bit more in detail. But you've heard this probably in a number of kind of discussions. We really need to focus on diversity, and we need to think about how we're going to address this challenge. This is a common problem and theme that comes around. I've had multiple conversations with, for example, Julie Lamong, who runs our MISHAR group. We struggle a little bit because of our geography and our patient population in terms of ensuring diversity, which is becoming a big priority for external sponsors. What I will say is that, even before the COVID-19 pandemic, but certainly after, we started to think really hard about how do we move beyond the traditional walls of our clinical enterprise. MGI has been enormously successful, but it's still kind of landlocked. It still needs to recruit within our clinical workflows. And so thanks to great staff, leadership, Janet Holtby is probably the person I'd call out as being really a visionary in terms of thinking through this. We started the Michigan and U Partnering to Advance Research Together, or the MyPart study, where recruitment now happens remotely. There's online enrollment, and then a spit kit is mailed out and through UPS sent back. In addition to that, just online or remote recruitment, there's been a lot of innovation that's happened, trying to leverage the My U of M Health Portal to recruit individuals, allowing for self-consent for greater convenience. And what's happened recently in the last few months or so is by implementing many of these strategies, we've seen a twofold increase in new recruitment to about 100 participants per week. And that's with just really 4 FTEs involved. So when you think about this, I mean, it's pretty remarkable. And what's most exciting is right now we're applying it to Michigan Medicine participants, but we've thought really this can really let us go beyond those walls now. And one of the pilot studies that we've started with in this last fall is to think about how do we think about broader and better data now. We've got a lot of great partnerships. Christine Ajrou, Salim Hayek, who's here today, have been thinking about new communities to start to try to reach toward. One of which I just want to emphasize here, and it has been our first kind of foray into this field, has been the MENA community. Obviously, Dearborn is one of the most visible and important Middle Eastern and North African communities in the United States. And so last year, we started to recruit through the Arab community clinic called Access, as well as started to make inroads towards the U of M Dearborn campus to try to hit this important ethnic group. And we're really excited about this as a proof of principle, but I think it'll allow us to think more broadly. I've already talked to Julie Lamong about, how do we use this to maybe think about integrating better with U of M Health West on the west side of the state, or even the recent purchase or partnership with Sparrow Hospital in Lansing, and how we think about integrating those communities into our work. The second area that we thought a lot about is the help implementation pathway. I mentioned it before. We have worked now to get a number of examples through the system. MCures is a risk deterioration tool that was developed around the time of the COVID-19 pandemic. Picture is another risk deterioration tool that's been developed by a different separate U of M group. And then the C-Diff tool that Jenna had developed along with her team that I mentioned earlier, as well as the growth of genetic indicators modules. Now these are all coming our way, and yet we had no real good pathway for how do we start to evaluate these tools in real practice. And in partnership with HITS and the Clinical Intelligence Committee, which is led by Karandeep Singh, one of our precision health faculty, we now have a path to pilot, embed, evaluate, and then implement these algorithm-based models within real-world clinical operations at U of M Health. And I'll just say again, this is a major, major achievement and pretty rare amongst most academic health institutions. This is just an example, just to let you know that this is actually live right now. This is an example from the C-diff model, but you could go into the Epic MyChart environment and get a score for a hospitalized patient on their risk for developing a C. diff infection. And this is actually being used now by clinical operations teams to actually change patient care and to try to understand different interventions around antimicrobial stewardship and infection prevention. And then the final thing I'll just mention in terms of what we've been thinking about, again, this was alluded to a lot by Dr. Runge, is data sharing. We're going to hear a little bit more about this from the next speaker, Kate Spector-Baghdadi. We've thought a lot about this. It's interesting. There are different models for data sharing, certainly across not only other institutions, but even within our own institution and stuff. And I think we've done this in probably a really principled way, which has been exciting to see. And again, I just want to emphasize, there's multiple examples, but prompt has been one that we've learned a lot from. But there's also others too. There's the large mobile health study, MyPac, that's taught us a lot as well. And that brings in the additional challenge sometimes of working with an external sponsor. But we've made it work. And even though it's taken a little bit of time and effort, I think it's really going to lead to great dividends. And then finally, I'm just going to end with our people, because this doesn't happen in a vacuum. This is a slide for just to acknowledge the leadership that's been really supportive of this effort. This was a big investment by the University of Michigan, and we're all very appreciative, and we've been trying to be good stewards of the money and resources that have been allocated to us. There have been a number of people who have really helped get this off the ground, and these are a number of those folks here, several of whom are in the room, and I greatly appreciate all their care and efforts very early on. This is the current precision health leadership. And again, I just want to acknowledge my two co-directors, Jenna and Sebastian, who are just a joy to work with. I think it's a great example. There's an old saying, you don't want to have 3 quarterbacks, you want to have 1 quarterback, right? But to be honest and stuff, at least in precision health, having 3 quarterbacks has been great. And I think part of the reason is Rachel has helped keep us in line, and it's been really wonderful working with her as well. And we've had just a number of wonderful faculty to work with too. And then I'm going to end by just really acknowledging the staff. I think as opposed to lots of other programs perhaps where the staff are there to kind of execute things, much of the vision and creativity and the solutions have actually come from our staff, and they've been just amazing to work with as partners in this whole thing. And I'm just going to end by acknowledging their contributions and just really letting you know what a privilege it is to work with them. So with that said,